Hello, everybody. Welcome back to the Incubator booth at NeoHeart 2024. We are joined with now our good friend, I guess.
We like to think
we can
so.
say you're a good friend. Phil Levy from Boston Children. Phil, how are you today?
Great to be here. We are definitely good friends.
I agree. But sometimes you say that, but maybe it's not reciprocal. I don't know. I have to get confirmed.
People like us, to hang out with us, so we just making some assumptions here.
No, we're sharing restaurant, choices in New York City. That puts us in the friend category.
That's right. You were roped in to do one of these year in review talks. That seems like really a trap.
A daunting task.
Oh, yeah. It was, in the grand scheme of everything, it worked out great. But yeah, when you sit down and think about, I have to summarize a year. And then they said, no, we want 18 months.
Oh.
18 months worth of neonatal hemodynamics.
Which is such a hot topic, right?
It's very active.
It's becoming very prolific. So
they said no abstracts, but you just got to kind of dive deep into it. So I said, okay, I'm going to do this. And I did what everybody does. I put in neonatal hemodynamics into PubMed, and I got thousands of entries.
Yeah.
So then I put some quotations around it, and I narrowed it down to a couple hundred. And then I went and I looked at the Neonatal Hemodynamics Research Center, which is just a great place and a great resource if you're interested in neonatal hemodynamics. You kind of start there, and it links you up to the American Society of Echo, and it links you up to the Iowa group, and it links you up to Gabriel Tit out, in Montreal, and references to French and Spanish and English. The long story short is I ended up kind of pulling all these articles, and I said, you know what I'm going to do? I'm going to group them. If there are 3 to 5 articles in a different subsection of neonatal hemodynamics, then that's how I'm going to kind of present the data. Because neonatal hemodynamics is not just neonatal hemodynamics, it's delivery room resuscitation, kind of what Anoop does. There's congenital heart disease, like the Learn CHD group does. There's transitional hemodynamics, like Iowa. There's hypoxic ischemic encephalopathy. There's sepsis. There's CDH. There's necrotizing enterocolitis. And then there's the whole training guidelines, POCUS. So I said,
That's why it's so hard to learn.
Yeah, you don't know where to start.
That's right.
And you got to be subspecialized now. It's kind of like you do a cardiology categorical 3-year fellowship, and they have all their subspecialties. Right. So I said, that's how we're going to break it down. So I went through all the literature, and truthfully, one name kept coming up, and I was just like, this is strange. And, maybe I can just focus on this one person and this kind of this team. And it was Reagan, we all know the impact that she had, Reagan Geisinger from Toronto, then Iowa. She had a huge impact on the field, and she passed away too early, 2023, but some of her work has lived on. She published 21 papers since leaving us. And I said, well, this is what I'm going to present. So I decided to put her papers and then some of her trainees' papers.
That's what I was going to say. She also leaves a legacy of trainees that are exceptional.
Correct. And that's how I kind of focused the talk. So brought up one of the first articles in the Blue Journal, American Journal of Respiratory Critical Care Medicine, which really outlined a hemodynamic screening program and really looked at screening for the PDA, looking at acute pulmonary hypertension, and looking at cardiac dysfunction. And this was a retrospective study, but it was fantastic in the sense it was the first time we could see some outcomes with actually doing a rigorous hemodynamic screening program. And their initial outcome was simple, severe IVH or BPD, and they looked at a group post-2018 who got hemodynamic screening, and it showed that these kids had less severe IVH, less death, they have less neck. What was fascinating, though, and this was compared to their historical controls, is if you look at the Iowa data in general, even pre-hemodynamic screening, pre-2018, their data is fantastic. I mean, now they're resuscitating 21-weekers, which is a whole nother podcast.
That's right.
But I said, okay, that was the first article. Then I said, let's look at the traditional PDA stuff. How does that look? Now, everybody groups the PDA into like gestational age or birth weight, and it's hard to tease out this stuff. And we know that there's all the trends. We're using more devices, less ligation. But what I loved about this study is in the hemodynamic PDA screening protocol, when they looked at 22 to 23 weekers and compared it to the pre-2018, they actually were treating more of the 22 to 23 weekers with pharmacotherapy, and they were doing less definitive closures compared to the historical controls.
Mm.
Then they looked at the 24 to 25 weekers, 24 to 26 weekers, and they actually were treating more babies with pharmacotherapy. So it's really just this whole paradigm that you're looking at. But the long story short is with hemodynamic screening, focused on the PDA, focused on acute pulmonary hypertension, they were seeing better outcomes. And then you see all the work that comes from Reagan's trainees, as you nicely alluded to, the use of inhaled nitric oxide. You know, you get that 2011 statement, you should not be using nitric oxide in babies less than 32, 34 weeks. Well, all the data that's been coming out, it's kind of mixed. Even Satyan's group put out a really nice paper on the use of inhaled nitric oxide in babies less than 34 weeks, about 3% of the time you use it. And, you know, some people will say, well, if you give nitric oxide to a certain patient population, they have worse outcomes. But what Satyan said is actually those babies are just sicker.
Right.
You know, it's not the nitric oxide.
That's why you turned it on.
That's why you turned it on. Exactly. What Reagan's group did, it was really fascinating. What she said is, I can't group all the babies under 34 weekers. Don't look at the 27, 28, 29 weekers. Let's focus on less than 26 weekers. Let's look at responders versus non-responders, babies who are on nitric oxide for 12 hours or more, and a responder is if they went down in their OI or their FiO2 requirement by 20 points or 20%, however you look at it. And fascinating, the outcomes were more improved. Now, the statement positions that have come out from the Canadian Pediatric Society, and this is, again, what I highlighted in the year in review, was that nitric oxide is not for every preterm baby, but there is a subset of babies who are born really young, less than 26 weeks, who have hypoxic respiratory failure, who have what we call acute early pulmonary hypertension. I'll touch upon that, where they may show a response. So they are the ones who would benefit. Now, the acute late pulmonary hypertension, so acute early pulmonary hypertension is like persistent pulmonary hypertension of the newborn. The PVR stays high. The acute, and that's under 3 days. The acute late pulmonary hypertension, so 3 to 7 days, are the HIEs, the not the meconium aspirations, but the sepsis and the neck kids. Those kids are probably not going to respond to nitric oxide, so you should be careful in that group. But really, for the first time, people have delineated out the phenotypes of acute pulmonary hypertension in the preterm population and found a medication that may work and tied it to outcomes. So to me, that was like, oh, that was next level novel.
Yeah.
And then if you look a little deeper in that hemodynamic screening, they talk about function, right? Right heart and left heart function. But in order to assess that in premature babies, you need to have normal values. So that's the other piece that Reagan Geisinger spent her career looking at. She summarized all the papers and looked at all the normal values. And then she listed out very clearly what's normal right heart and left heart function, what's normal pulmonary hypertension measures for the term and the preterm, and then looked at different disease states. She showed that they're feasible and reproducible. She showed that they're normal values and they tell a story. And then she started to use these measures as endpoints in different studies. And to me, that was the next level.
Wow.
Then she went a step farther and she says, okay, I know what the normal values are. I'm going to look at babies with hypoxic ischemic encephalopathy. So this was the next phase. Babies who underwent therapeutic hypothermia. And this is one of my gold star papers in the sense that when you have a baby who has an initial injury, and then you make the very difficult decision to cool a baby, because I don't take that lightly, she showed us that when you cool the baby, the markers of pulmonary hypertension get worse. Your PVR goes up. Your function may stay the same, but so when you're cooling a baby who already has evidence of pulmonary hypertension, you're making the conscious decision to save the brain at the expense of the lungs. So that was just a total novel paper. And then I summed it all up because in 2024, we had an awesome opportunity to update the 2011 targeted neonatal echocardiography and point of care ultrasound guidelines that were published in the American Society of Echo. Now, Patrick McNamara put it together. He's the first author. You should go look it up in JACE, Journal of American Society of Echo. And basically, he tasked every single person with one job on that committee to write one section. Reagan somehow wrote many sections. And it was just fantastic. And we put out the guidelines. It was all about teaching and education and training and breaking it down to different kind of subsets of disease states. And I'll highlight this. Erica Rosenrod Berman, who is a professor of pediatrics and a world expert of pulmonary hypertension at Columbia, and now is going to become the department chair at Westchester Medical Center, Maria Ferrari. She highlighted Reagan's work without even knowing that I was going to highlight the same work. So that really trickled down into the impact that we all felt. And finally, I ended the talk by asking everybody, have you ever published in the JAPOS journal? And everybody looked at me with a big question mark over their head. And the JAPOS journal is like the big journal for ophthalmology. And Reagan had the foresight to look at the impact of a hemodynamically significant PDA on retinopathy of prematurity and death. And why they chose to publish in that journal, I don't know. But Reagan and her entire team, Danielle Rios, Patrick McNamara, Adrian Bishop, they are not just about extending the information about hemodynamics to our community. They took it a step further and went to the ophthalmology community. And I just was like blown away by that. So I think it's really pertinent in today's landscape that we highlight these articles, but bringing it back to what we love to always talk about, the PDA. We never know what to do with the PDA, but in 2024 and 2023, so many societies and big registries finally published their data on trends. You had FIS, you had Vermont Oxford Network, you had the Children's Hospital Neonatal Consortium, you had the pediatrics group, basically showing that we have a sharp decrease in the amount of babies that are getting surgical ligation, although there are some, and we published a paper on that in 2024, who still gets surgical ligation, so abnormal morphology, rip-roaring sepsis, or neck, or the babies are really too small, they still go for ligation. And then we see a sharp rise in device closure, the PDA. And the real question is, what's the timeline of it? And a recent paper actually published last week in the Journal of Perinatology, Suvik Mitra is the first author. Highly recommend everybody go reading it. It ties in the Canadian Pediatric Society guidelines from 2022. And the long story short, if you're a center that does hemodynamic screening at 1 to 3 days, if you're a center that does symptomatic screening, if you're a center that doesn't believe in looking at the PDA in the first week and you don't want to wait till the second week, the bottom line, everybody says this: the earliest you would consider device closure of a PDA is 10 days of age. And that's a common theme.
Yeah. Sunday, August 11th is when we were reviewing that paper on the podcast. We've actually already recorded the review. And so I was talking to Shovik earlier about this. This is a phenomenal paper because what I was telling Shovik about that paper about the guidelines is that when you read the titles and you read the objective, you're like, this could go far and wide. Like, this is going to go all over the place. And you guys contained it in a way that was impressive. And so I really liked those recommendations.
Yeah, and it gets, I think it's important to understand how you define a hemodynamically significant PDA, but that is controversial. It's important you pick the right pharmacotherapy to treat the PDA. But at the end of the day, the pathways all lead in some babies that you want to close it, right? 30 to 40% of the PDA closes within 2 weeks. 40 to 50% of the time, the PDA will stay open and it won't cause problems. So they're still left with a percentage of babies that need to have their PDA closed. At the end of the day, Suvik and his team have really, really outlined exactly the steps needed to get to definitive closure.
Yeah, it's guidelines are awful to read. Like it's all usually awful. And this one is so nice. You divide it into 2 categories. You had like, what kind of background questions do we need to answer? What kind of intervention questions we need to answer? I think there were 4 background questions, 2 intervention questions. And then asking like, how long can leave a PDA open? What is the gestational age? And you incorporated everything into it. I'm not going to spoil too much the paper and the journal club, but you involved the medical aspect of things. You involved which type of center are you? Like, is this something you're struggling with? What is your mortality rate like? And then you involved also communications with families. Like, take all that information, bring it to the bedside, share decision making, and then come up with a decision. So I really, I reviewed that paper. I really liked it.
No, it's awesome. And you know what it highlighted to me, and this is what highlighted the guidelines that we did also, the American Society of Echo, which are they're 46 pages. They're somewhere around there. Highlighted to me that you're involving neonatology and cardiology. And that's the theme of this conference. I mean, we had a great session this morning on the preterm infant with congenital heart disease. And that can go in so many different directions. But at the end of the day, the take-home message was you need to involve the cardiac and neonatal intensivist, the cardiothoracic surgeon, the interventionalist, nursing, nurse practitioners, respiratory therapy, nutrition, And that's the theme of the whole conference.
And people have to understand that some people may say, oh, this is really niche-y and whatever, but it is something that we are seeing more and more of. And you mentioned to us off air that there's even interest from the American Academy of Pediatrics from a resuscitation standpoint. Can you share anything without breaching any?
Yeah, no,
NDA?
that's a great point. So a lot of the work with simulation in the delivery room has revolved around preterm or term infants, but most of the work out there had excluded babies with congenital heart disease. And if you go talk to Carl Baxter and Nuke Katharia, who've done all the cord milking, even the original studies excluded the congenital heart disease babies. But about 4, 5, 6 years ago, led by Noura Ali out of UT Southwestern, we essentially created a collaborative called Learn CHD, which is developing modules in the delivery room setting that allows us to properly care for babies with critical congenital heart disease. And the idea was to develop these e-learning modules, disseminate them on a large-scale base, obtain funding, and then one day in 5, 10, or 15 years, end up. The long-term goal was to work with the NRP and AAP, but that timeline, thankfully, has been sped up. And without giving any major details, we're hopeful that within the next kind of iterations of NRP that we all take, every 2 years, you're now going to see modules based on resuscitation of babies with congenital heart disease in the delivery room. And that is a real testament to the NeoHeart group, to the Learn CHD group, and really tying together the neonatal and cardiology groups.
That's awesome.
Yeah, we can't just keep ignoring a big population of babies that we all take care of. We resuscitate in the delivery room. We take back to our units.
Right. And we approach developing these modules. They're not just for the high volume centers.
Right.
Yeah.
They're not for, I'm fortunate I work at Boston Children's Hospital, but they're not just for Boston Children's. They're for hospitals all over the country and hopefully all over the world. You could be any, I could say, practitioner, any person who cares for babies in a delivery room, from an obstetrics nurse to a neonatal nurse to a neonatologist. You will be able to use these simulations to enhance the care for these babies.
Yeah, we had Dr. Felipe Hernandez from Mexico who said, I'm not in a big cardiac center, but when those babies are born in my center, I have to take care of them until I'm comfortable enough to transfer them. And the management is critical, and I need to.
It's true across the U.S.
Across the U.S.
Sure.
Across the U.S. But that was something that was brought up as well. Phil, thank you so much for coming and sharing some of the pearls that you shared at NeoHeart.
Your wealth of knowledge.
Yeah. And best of luck on your way back to Boston.
Thank you. Great to be here.
Thank you.